Jill. Thank you. Have a good one. See ya. Well, what great surprise here. It's Tuesday, April 7th. Just came out of the office, heading back home. It's around 3:30 p.m., which would have been normally big time traffic time, rush hour, right out here on the street, which seems to be deserted, obviously because of the COVID-19 crisis. Everyone's inside, except for the crazy dentists like myself, who have to be out and about every now and then to see emergency patients. Of course, this kind of brings up a very interesting concept here for us, especially dentists doing endodontic therapy, and specifically endodontists, as to our obligation to our patients who are in pain. And to what extent are we going to let fear overcome our oath to our patients in terms of taking care of them? So what I have been doing, obviously due to the mandate by the local government, as well as the recommendations by the ADA and the AAE, what I have done over the past few weeks, where the office has been officially closed, I've been seeing still emergency patients that are truly emergencies. And we're talking about generally fascial space infections that require drainage, necrotic teeth that have swelling, it's not responding to antibiotic care, or some patients that have acute irreversible pulpitis where for some reasons they're not going to be able to wait, or the pain is too much. So for the most part, if people have inflammatory pain such as pulpitis, could potentially be addressed by taking anti-inflammatories and waiting for the infection to resolve. And patients that have actual necrosis, many times antibiotics can't take care of the problem. Of course, antibiotic care, as we know, over prescription of antibiotics for necrotic teeth has caused a whole set of other problems which you don't want to have to deal with in the long run. But at the present time, it seems like this may be something we have to do. Treatment of necrotic cases that are symptomatic with the first course antibiotic treatment, which would probably be something like just a PenVK, penicillin or something like that. That would be more focal and more specific to the type of infection, odontogenic infection that we're dealing with. And if it doesn't respond, is to move on to something more broad spectrum. It's probably not the best idea to give them a broad spectrum antibiotic right off the bat. But what I kind of was thinking about as well today, as I was treating these couple of patients that had this kind of an infection, was the treatment philosophy. I think the time for some of those differentiation factors, such as minimally invasive endodontic therapy, ninja access preparations, tiny little access things, all of those things that many of my colleagues have been over the past few years kind of trying to differentiate themselves as experts on, that time is over. Right now, the only thing we need to do is we need to be able to achieve our standards of cleaning, shaping, and disinfection and obturation as efficiently as possible. And that is just not possible through these contracted access preparations and minimally invasive approaches. Traditionally, a minimally invasive approach required the use of minimum instrumentation and relying heavily on irrigation and chemical disinfection, including the use of calcium hydroxide. But we now know that since we're going to have to rely on efficiency as probably the best mode of reducing the amount of time the patient spends in the chair and in our care, to reduce the clutter in our waiting room with patients and so on, we need to be fast. That's basically what it comes down to. And by fast, I don't mean just being fast and sloppy, but rather efficient, which means achieving those high standards that we want to achieve in just less time. And what I've come to the conclusion of over the past few weeks of having to deal with emergencies where I've had to be super quick is that a 06 taper preparation, a larger type of a taper, will allow me to much more quickly and efficiently clean the debris off the walls and disinfect the root canal than much smaller taper preparations. And the reason for that is because smaller taper preparations leave a large surface of dentin still untouched, and that is essentially part of the problem here, is that we need to rely on mechanical cleaning of the canal wall, which involves removal of the dentin as the most efficient method of kind of cleaning and removing biofilm and tissue off the walls. Of Of course, alternatively, what we could do also is we can use three-dimensional instruments that allow you to do that in much less time. And I think when it comes to that, 3D instruments are going to be very helpful. Of course, the problem with 3D instruments is that you're going to end up having a little bit more of a challenge with the obturation part of the treatment, because you're going to need to still cone fit, and that might take a little bit extra time. But perhaps combining the 3D instrument with an 06 taper instrument will allow you to get the best of both worlds, of both cleaning and disinfecting and also facilitating obturation. So let's go inside so I can basically show you guys what I'm talking about with the use of 06 taper preparations, and specifically with the EndoSequence 06 taper. Essentially all you need is about 2 or 3 files to get a fairly decent preparation that is very predictably fitted for your obturation that you can then fill with your BC hydraulic condensation technique. So let's go inside and take a look at this technique.